In this country, we have a major issue with how we care for people at the end of life, particularly for patients with cancer. So there's a lot of data that you can see through Medicare databases and actually insurance claims about how patients receive really futile, very aggressive care at the end of life. So there's tremendously high numbers of hospital admissions for patients who are really nearing death. Patients going to the ICU, the intensive care unit, receiving invasive procedures and radiologic studies, and ultimately dying in the hospital.
For the vast majority of those patients, that additional treatment not only doesn't help, however you measure it, quality or quantity, but it can be harmful, and it creates unrealistic expectations and makes the process harder for the patients and the families.
The objective of the healthcare system should be to provide the right kind of care at the right time to the right people, okay? And if you have a patient who is getting treatments that do not have any benefit to their health and longevity, then you're failing. The system's failing.
The question we had was, can we actually use the data collected by modern electronic health record system to help us produce a more objective measure or more objective prediction of how long a patient can expect to survive?
Is a tool that's available here in the EHR. It's a commercially based tool called the Rothman Index. And it takes many, many different data points and is continually updated throughout a patient's time in the hospital. So it looks at things like vital signs and lab tests and nursing assessments and physical exam. And we've seen that the Rothman Index is a good predictor of hospital readmission and some other utilization metrics. And so we combined the Rothman Index with other factors that seemed to predict the likelihood of dying in the short term. We were able to come up with the IMPACT, which is the imminent mortality predictor in advanced cancer.
Patients that our statistical algorithm identifies as likely to die within 90 days of their admission to the hospital, their median survival time from that point is around 52 days. Patients that we did not classify as likely to die within 90 days, their median life expectancy was 250 days. And that gap and that difference is the opportunity here, because that gap represents more time that a patient could spend getting hospice care as opposed to more intensive hospital-based care.
Hospice is a form of care that's really focused on caring for the entire patient and focusing on comfort and quality of life at the end of life, whenever possible, to keep patients at home with their loved ones. Overall, sort of whole patient-centered treatment, caring for the whole patient in that sort of end-of-life situation. And that really has been shown to decrease patient and caregiver distress.
By moving patients to the hospice earlier on, based on estimates, we can save roughly $1.9 million per 1,000 hospital visits to the Smiler Cancer Center. We've been talking about electronic health record systems for a long time, and now there's several big vendors which sell these systems to hospitals, and you're seeing them being put into place. And that not only does it allow us to create these tools and build them into a standard clinical workflow that physicians can have access to in real time, it also allows us to extract this data set and use them for other analyses as well, to answer questions that we might not have thought about in the past.
We want to go from a world in which we're making predictions about life expectancy based on aggregate statistics, where we might say that a patient with a certain that 20% of patients with this condition survive, say, X months. We want to say, what's the probability that you as an individual, based on what we know about you and health data we've collected about you, what's the probability that you will survive less than a certain amount of time?
We had really tossed a lot of balls up in the air to say, who can help us figure out how to make such an objective prognostic tool? And somehow, by luck, we were able to meet EDIEAL Pinker and Donald Lee.
The genesis of this project was at Smilo, and we came on as the experts who could provide the techniques to analyze the data and make the actual predictions and build the prediction models.
As an applied researcher, it's absolutely necessary to work side by side with practitioners to find out what questions are actually important to study. And our oncology colleagues over at the Smilo Cancer Center has been very good in providing us with expert domain knowledge in the cancer arena to help us better refine the accuracy of a model.
The collaboration with our colleagues at the School of Management was incredibly gratifying. It was very stimulating from an intellectual standpoint, and really taught us a different way to approach this problem. It really helped us understand how this can be interpreted other than just the very traditional clinical bedside tools that we use in our practice.